just wanted to ask that in this experienced patient, as Dr. Ketan Bhai questioned, that in some experienced ART experienced patients, if they get neurocognitive disorder, is there any experience of yours of doing resistance testing in CSF?
Yep.
For and is there any difference between
yep.
The blood and the CSF resistance?
Yep. I mean, I'm going to show a case of somebody who had CSF rebound with plasma undetectable. But in my experience, it is incredibly rare. I've had in total less than 10 cases where that has been the case. And we have a hand clinic where as soon as they have, got neuropsychological impairment, they have an MR scan, they have an LP, we look for HIV viral load in the CSF. Nearly all these patients are taking heart, and nearly all these patients have undetectable viral loads in the CSF. When you have a detectable viral load in the CSF, it's conceivable you have resistance there and you don't have it in the plasma, and you can have the alternate too. You can have resistance in the plasma which is not detectable in the CSF, and it suggests that you can establish a virus in the CSF and that can stay there, and you may get a different virus through selected mutations developing in the plasma which doesn't get into the CSF. So you have two populations of virus. And so that, you may have an undetectable viral load in the blood and you have detectable virus in the CSF, and then after a while that goes back into the plasma and then you get a spike of your plasma. So you get rebound in your plasma because you've never eradicated the virus from your sanctuary site. I hope that answers the question. So moving on to minor neurocognitive disorder. This is a 43-year-old woman from Africa, diagnosed in 2005, obviously needed to go on to treatment. No problems, no comorbidities, examination unremarkable, certainly no neurological problems. Commenced on Atripla, which is our first-line therapy and has been for many years, but didn't take her drugs very well, and as is always the concern with Atripla, quite quickly developed an NRTI resistance, switched to Eluvia, tenofovir FDC as Truvada, adherence improved and got an undetectable viral load and a good CD4 count. So an excellent response to the drugs. But then it came disengaged with care again, so didn't take a treatment properly, and represented two years later, the beginning of the year, low mood, memory loss, no interest. So that could all be due just to depression. Started to forget appointments, pills, and school runs. And my experience of mothers, they can miss their pills and appointments when they're depressed, but they won't miss the school runs. So that suggests that there is something going on. CD4 count 186, viral load has gone up, so that's a result of not taking treatment. So has neuropsychological testing which is positive and shows that there is neuropsychological impairment. Has an MRI and LP, both of which are normal. Adherence is facilitated as best possible, but the working diagnosis, because she is symptomatic, is that she has mild neurocognitive disorder. It is impairing her life, her neurocognitive impairment. So how do we say somebody's got neurocognitive impairment? And this is a slightly confusing slide. You have to, in the neuropsychological test, to make this objective, examine at least 5 domains. And you can see here that they are attention, executive function, verbal learning, verbal memory, and fine motor. And as an example, one of these is the fine motor skills, and that's this grooved pegboard, where you have to get so many pegs into the holes in 30 seconds. And so you've got an objective measurement of that. The colour trails, test 1 and test 2, examine how you can join dots together, either with colour or without colour. And then you've got verbal learning and verbal memory tests. And to have a normal one on the Gaussian distribution, you're above 1 standard deviation below the mean. If you're below that, then you have an abnormal test. So you do 5 tests, and don't look at these in detail. And our patient had 3 that were abnormal, for example. She therefore has neurocognitive impairment, because she's got more than 2 domains that are impaired. and she is symptomatic because it's interfering with the function in her life, as opposed to be asymptomatic. And so you have this, we've talked about dementia, this is minor neurocognitive disorder, or mild MND. Then you have patients who have those tests but have no symptoms whatsoever, and that's ANI, and that's part of the triangle. And so from the pre-heart to the heart area, what's happened is there's no longer anywhere near the amount of dementia there was, but we're seeing more minor neurocognitive impairment and asymptomatic neurocognitive impairment. So again, of the patients that we see, you can see how they're split up. Actually, it's about 50% in most studies have any degree of neurocognitive impairment. But you can see 10% roughly have symptomatic neurocognitive impairment, like our patient. And just to remind you, it's impairment more than one standard deviation in 2 more of the domains that are measured, which interferes with daily life. And so looking at scanning measures to measure the amount of frontal lobe, one can see that there's a gradation which increases or decreases from normal down to patients with HIV-associated dementia. And if you look at various neuropsychological tests, you again have this gradation from people who are normal down to people who have AIDS dementia. So it's going to be a problem, isn't it? As patients now survive, 85% of our patients are now on treatment and are going to live a good lifespan, and dementia is going to start raising its head. And what about these patients who have asymptomatic neurocognitive impairment? What's going to happen to them in the future? Are they going to stay the same? Are they going to progress? So these are studies that have been done. This is a study as an example where it's a simulated driving test. And you can see that there are various things here: response time, reflex time, steering variance. I think that means how straight you are with the steering wheel, speed, and I don't know what weighted crashes are. But at the end of the day, conclusion is that there is impairment, even if you test for it very sensitively, very sensitive tests. You can see this even in patients who are asymptomatic with every other from every other function that one looks at. And if you look at patients who have asymptomatic neurocognitive impairment and follow them up 4 or 5 years, about 40-50% of them go on to develop impairment with their function. So they get mild neurocognitive disorder. So it becomes symptomatic. So, how do you screen for hand? Am I doing all right for time? How am I doing? Am I okay for time? Okay for time? So there are lots of screening tests, and I put the words across it because I don't want you to follow any of them. These are the 3 tests we use in the clinic, and they're the 3 tests that the European AIDS Clinical Society recommend, which are: do you experience frequent memory loss? Do you feel that you're slower than you were before? And do you have difficulties paying attention? And if you have any of these that are positive, then the patient goes to our HIV psychologist and has a full neuropsychological assessment for neurocognitive impairment. And this is what happens in our clinic and what happens on the EACTS guidelines, their recommendations. 3 questions are asked every year or 2 years. Abnormal. Depression is then assessed, excluded in the neuropsychological examination. If the neuropsychological examination is abnormal, they have an MR scan, a CSF, and if every other cause of neurocognitive impairment is excluded, then the diagnosis is HIV-associated neurocognitive impairment. So this patient with a mild neurocognitive disease who stopped taking a treatment, restarts her treatment again, is referred to the psychologist for memory rehabilitation programs, gets a lot of adherence nurse and social worker input, and gets a viral load undetectable. And her family, it's always important to get corroboration from the family, agree that she's become better and more focused and is able to be independent again. So that's a sort of milder case, but in the gradation towards dementia. And that is, I think, the concern is, even if we give these patients heart, the evidence that these patients actually get significantly better is not great. So if there are no questions, I'll move on to what we do with HIV viremia in the CSF. This is a 45-year-old professional man, diagnosed 20 years ago, started on saquinavir and combivir, understandably failed that, and was put onto Eluvia with tenofovir and 3-TC, but switched in 2009 to atazanavir, boosted by ritonavir with Truvada because of very raised lipids. No problem from a virological perspective, previously no neurological symptoms, and then he presents with a general slowing down, not concentrating so well, not being able to focus on what's being said so well. Nothing to find on examination. Psychological testing confirmed that he had more than 2 domains which were positive. He has an MR scan which is normal. He has a CSF which is normal except his viral load is detectable. And remember, his plasma viral load is undetectable. The CSF viral load is wild type. The plasma viral load is undetectable, so can't have resistance testing, but he failed saquinavir, AZT and 3-TC. So he's undoubtedly got some archived thymidine mutations and 184. So again, on the EACTS guidelines, and pretty well what we follow, if they have CSF viral escape, we do their resistance test on their CSF, and this was wild type in this particular case. There's no test we did prior to starting him on his Kaletra in 2000 with tenofovir and 3-TC, so we don't have any other resistance test. And then include potentially CNS active drugs. So better CPE is what that's saying. And what is the evidence for this? This is not my case, this is somebody else's case. And on the left we have, and Ashish may be able to comment more on these scans, but on the left we have somebody with a high viral load in the plasma prior to treatment, and it shows some frontal lobe, periventricular white matter enhancement, subcortical enhancement as well. And then in April 2010, after being on Eluvia, tenofovir and 3-TC for many months, the viral load in the plasma is undetectable. In the CSF is still detectable. The patient still has neurocognitive problems. In March 2011, having switched then to raltegravir, nevirapine and 3-TC, which increases the CPE score somewhat, but not significantly, there is improvement in the scan. And the viral load in the CSF is undetectable. One case does not, mean very much. And the trouble is there are other cases which are the exact opposite. But it does give one food for thought, if nothing else. So we've known for a long time that if you don't control your viral load in your blood, you don't control your viral load in your CSF. If you don't control your viral load in the CSF, then you get neurocognitive impairment, and the more severe your impairment, the higher your viral load in the CSF is likely to be. We also know that with the exception of T20, all drugs penetrate into the CSF and all have activity on virus in the CSF. Now on the left-hand side, I'll use this, trouble is, here we go. These are where you've got parallel. These are CSF and plasma responses that have been done at the same time. And all these patients here have had parallel responses, so they've gone down at the same time. Now you've got here where they're on the right-hand side, and I've lost my cursor completely in the white background, but there he is, or she. And here you can see that the CSF is much slower, the red is much slower, and in this one and this one it's actually gone up. So why is this? Well, it's known in patients who've got AIDS illness that it occurs, or low CD4, it occurs much slower. It may be because you're not using drugs that penetrate well into the brain, and certainly the CSF, as in this side, on the left-hand side, where one is. Or it may be that you've got a resistant virus. All those are possible, but that has been recognized for some time. So how often is this due to CNS penetration, and could this be due to that? So, for instance, drugs penetrate into the CSF in different amounts. Here on the left-hand side, we've got darunavir. Here we go. And this is the plasma, this is the CSF, and this is the IC50 for the virus. So there's plenty of darunavir to kill the virus in the CSF. This is with lopinavir, and again, this is the amount in the CSF. That's the IC50, plenty of lopinavir in the CSF. Of course, these are all healthy controls. And here you've got atazanavir, and here's the IC50. And atazanavir is actively extruded from the CSF through transport mechanisms. So you do not, with atazanavir, get the same levels in the CSF. And a lot of patients don't have enough atazanavir in the CSF to treat wild-type virus. For the non-nucleosides, this is efavirenz, and it's good. For nevirapine, it's even better. And for the NRTIs, it varies again. And again, without going into these in detail, this is the bacavir. The plasma is in, I shouldn't have done white background slides because you can never see the cursor. You see the background, some of these have undetectable viral loads in the plasma, and the CSF is detectable, but the majority of patients who have plasma levels have similar levels in the CSF. About 40% gets through to the CSF. And here you're looking at the nucleosides. Zidovudine, abacavir, and FDC penetrate very well. For the non-nucleosides, nevirapine and efavirenz, and for the boosted PIs, you can see boosted indinavir, darunavir, fosamprenavir we don't use much, Kaletra, and indinavir unboosted on the CPE score penetrates very well, and that's to do with protein binding. This is the patient when they were on treatment up until 2009, so 4, 5, 6, 7, 8, 9. Then they switch, and it goes down to 3, 4, 5, 6. Is that relevant? I don't know. Here you've got somebody who's having plasma and CSF viral loads at the same time, and you can see in the CSF that 184V still exists and the CSF never becomes undetectable, but the plasma does. Technically, then, the CSF may cause the plasma to suddenly rebound. And that is one of the theories that could explain why some patients do get rebound in their plasma as a result of virus which never gets undetectable in the CSF/brain. So when you have this discord between viremia in the CSF and plasma, detectable in the CSF and not in the plasma, people have associated that with pleocytosis in the CSF, neurological disease. Some have resistance mutations which are not found in plasma. Some get better when you optimize it by CPE score, but again, there are other cases that have been described where it seems to be an incidental finding and there's no relationship to any neurological disease and no relationship to CPE. So this is really the CPE, the way the people who believe in CPE think. Here you've got HIV-associated dementia, mild neurocognitive disorder, and asymptomatic neurocognitive disorder. If you don't use any heart at all, or it's totally suboptimal, you go on down here and you get HIV-associated dementia. If you use poorly penetrating drugs, then it stays about the same. And this is sometimes what is found, that despite ART, patients do not regain their neurocognitive function, but if you use highly penetrating drugs, they actually get better. And that data isn't available. This is a small study called the Altair study, and its significance is not powered to show this, but it's interesting because you have 3 combinations and their CPE score varies quite dramatically, with the third combination having a CPE score, because it contains AZT, of 11. And they had a lot of sophisticated imaging and metabolic tests. Neurocognitive functioning, the combination that worked best was the quadruple combination with the highest CPE score. When metabolic activity was looked at, it was actually the efavirenz containing regimen that did best. So it's not easy to interpret, but in this particular study, the higher the CPE score, and this was a randomized study, the higher the CPE score, the better the neuropsychological improvement. So in our patient 4, in view of the wild-type virus in the CSF, we added combivir, even though we assumed that in the plasma there was archive resistance. because we felt in the CSF it was still wild-type virus. Raltegravir was added, possibly because of better penetration to sanctuary sites, but evidence for that is poor, but also to increase the CPE score. So very high CPE. Neuropsychological testing did show improvement. Viral load was maintained, undetectable plasma, and it became undetectable in the CSF. So finishing off here, my conclusion are it's a very neuroinvasive drug, and if you leave it there long enough, it will cause neuropathology, which you can both see on biopsy, but also see on radiology. You can objectively diagnose the level and severity of it by using neuropsychology tests, which have now been standardized. You should be doing repeated screening with simple questions in your clinic. I know that is difficult in some of the settings which you're working in, but 3 questions don't add to the length of the consultation. And in the absence of convincing evidence against the benefits of CPE, I do believe you have to optimize the CPE score where there is discordant CSF and plasma viral loads. Challenges for the future: why, if you optimize and even give them a high CPE score, do patients not necessarily get better? Is it viral escape in the CSF? Is it the drugs that have a neurotoxic effect? Is there permanent damage? Is it ARIS? Is the CPE important or not? I think we need to resolve that, and studies are underway. And what about persistent inflammation in the CS despite heart? How important is this, and how important is immune reconstitution? And I'll end there. And thanks for listening.
Yeah, thank you very much for opening dysfunctions in HIV. Now, any questions to Dr. Wilkins?
I have one. We have a patient. She is a young female and she is on antiretroviral therapy. I will not give a huge history because she had many problems initially, but now she was doing well since last 3 months on zidovudine, lamivudine, and efavirenz. And she has a history of ART of 1 year or so, and the adherence is very good. Now, since last 1 or 2 months, she is having similar neurocognitive disturbance and problem. The CD4 is good, the plasma viral load is undetectable, and if I calculate the CP of such a regime, it comes to 10. So, and MRI and CSF are normal. So, would we still suggest a CSF viral load in such patient to see what is the thing? And if the CSF viral load comes detectable in a good range, then what would be the regime which you would propose in
well,
such patient?
I mean, this is a typical patient that we face because we used a tripler, which has got a very good CPE score. And so what I would suggest is first, and it's not easy, but to exclude depression. And I presume you have made that assessment and do not think she's depressed.
Given antidepressants and patient didn't.
Well, that's even better. So you have to do a CSF viral load. I think you have to also make certain there's no other pathology going on in the CSF, but you have to do a CSF HIV viral load. Now, if that's increased, then you have got CSF escape, and then I think I would maximize it, and that would probably mean just adding a 4th drug, which is costly, I realize, but I think that would be worth a go. If the CSF is completely normal and you cannot find any other cause, then this is the problem we are facing. You know, you've got good ART, undetectable viral load in the CSF as well as the plasma, no, good CD4 count, no depression, no other explanation for this, and that they seem to have definite neurocognitive impairment. We're lucky we have a dedicated psychologist who does sophisticated testing, and that really does help because sometimes she comes back and says, that man's depressed. Sometimes she says, no, there's definite neuropsychological impairment here. You need to go on and do an MRI and get an LP done. And that really does help because I can't tell. And antidepressants may not mean that the patient isn't still depressed. But I think this is one of the questions. What do we do? I haven't got an answer for you. I'm sorry. If the patient was on azacitidine, ritonavir, and Truvada or tenofovir 3-TC, I would say, yeah, that's fine, you can switch. But they're on a good combination already. But I would do an HIV viral load in the CSF. I think you've just got to take it to that extra step.
Yeah, can I add to this? Why can't we are looking at the toxicities of efavirenz? Because
Yep.
it is a potent.
No, that's a good point. It is a good point, yeah.
And it can give you a depressions, variety of
Yeah.
psychological disturbances, including
Yeah.
suicidal tendencies. So why not? Because it is
Yeah.
3 months and even longer runs.
No.
The patient is on 6 to 10 years. The efavirenz is known to
No.
produce significant
Yeah.
neuropsychiatric disturbances.
I think that is a very good point, which I wasn't picking up on. But there is another point underlying it, and that is the neurotoxicity to the cells of efavirenz. Because if you stick efavirenz with cells, astrocytes and things, it's neurotoxic.
The last visit, my colleague had changed efavirenz to nevirapine, and she's not still responding.
Okay. Well, there you go.
So now second question comes when we expect a response once we make an appropriate change in anti-HIV medications?
I think you expect to you are surprised by a response. I think if you follow, what you would expect to happen, the viral load comes undetectable in the CSF. When that is undetectable in the CSF, that is presumably a reflection of improved virus levels in the brain. They've come right down. And when there are improved virus levels in the brain, there are less protein products, less cytokines, the brain inflammation is settling, and therefore the patient should be able to function better, and hopefully their neurocognitive impairment would improve. But, hey, I think the answers are going to come partly from very sophisticated imaging. I think that in the end, we will get much more information from that than we will from a CSF viral load. And I think when it comes to, measuring CPE score, I think that future, where is Ashish somewhere? I don't know, but looking at drugs and penetration of drugs to the brain tissue, that there must be a future through, labeling or something like that, at looking at the drug distribution within the brain. Some drugs we know in rats, they've done that sort of study with, in fact, Eluvia is one drug that they've done that with, which penetrates well into the brain, but only certain areas of the brain. But you can see that would give us a much better idea as to where it penetrates and the level it penetrates to. And then, one could either say, well, this is a load of nothing, or it actually seems to be very relevant. The CPE score does fit with the penetration into the brain tissue.
What is the association of other treatable causes of dementia with in patients with HIV when we suspect HIV dementia?
Well, I think it's like trying to diagnose sarcoid in this country when there's so much TB. I think trying to diagnose somebody with Alzheimer's when they've got HIV is very, if they're 30, yes, maybe, but if they're 65, it's very difficult to know if they've got Alzheimer's, which is the cause of it. Because you get the same pathology in the brain if you were to do a brain biopsy, which you wouldn't. So I think it's very difficult. You can normal pressure hydrocephalus is very easy, and that will be part of your standard, workup. We always do manometry now when we're doing CSFs, so we look for normal pressure hydrocephalus. And if you had multi-infarct dementia, that would come from the various imaging that would be done. But I think Alzheimer's, it's very difficult. Okay, lovely. Thank you very much.
So I'm going to continue the same neurocognitive problems and the different neurological issues in HIV. I'm going to discuss 2 cases, and I need attention of all the doctors, especially the Ashish and Dr. Wilkins. to look at these problems. So now, I mean, it's very clear. So I don't think I should give you a background of HIV, which produces the variety of syndromes into the central nervous system as well as into the peripheral nervous system. So let me start with my case. This is a 58 years old gentleman with 56 kg weight. He's diagnosed HIV in 2007 and was taking Zidovudin 3TC nevirapine from ART center, and he is HBV co-infected. He came to our clinic in September 2012 with diarrhea, weight loss of 15 kg and odynophagia. So he has classical clinical failure on first line therapy from ART center, and his lab workup showed 55 CD4 count. Hepatitis B viral load was below the level of detection. So he was on 3TC monotherapy, but he was maintaining fully suppressed hepatitis B, and HIV was very high. So he was treated for cryptosporidal diarrhea, candida esophagitis, and then started on tenofovir, emtricitabine, and atazanavir, ritonavir. He has a very good clinical, immunological, and the virologic response with gradual improvement into the CD4 count, and attained undetectable viral load in December 2012 with 9 kg weight gain, and he is asymptomatic. In July 2013, so this year in July, he complains of burning pain on light touch, that is allodynia, inner dermatome 7, 8, and 9. This is a dorsal dermatome, thoracic dermatome, and there is a progressive worsening and encircling pain surrounding the trunk since last 1.5 months. So whatever pain that he was describing now, it is progressive, and now it is entirely encircling the trunk in last 1.5 months, which was not responding to the supportive painkillers, which includes the NSAIDs, gabapentins, pregabalins, and all the supportive the things. And now the pain is disturbing his sleep. So he is much concerned. He is much worried. There is no headache, no memory impairment, no bladder bowel or the gait disturbances. So the higher functions were, I mean, normal, apart from this, the burning pain which is encircling the dorsal region. There is no history of herpes zoster, because probably we are looking at some post-herpetic neuralgia. But I mean, even if it is a post-herpetic neuralgia, usually it restricts to the one side. Here the patient is having encircling pain. The neurologist opinion was taken, and he advised MRI spine. Higher functions were normal. There is no cranial nerve disease, no cranial nerve pulses, motor were normal, sensory normal, except there is a hyperesthesia in the involved region, and the MR spine was normal. There is no abnormalities on MRI spine examination. And again, he has prescribed things, and there was no relief with the medications. So there were no clue from the laboratory and radiological workup. Now it's our time, because he was definitely frustrated. He is having controlled disease, significant pain, disturbed night sleeps. Now it's our turn to get frustrated after all these investigations. So we asked him to get hospitalized. So we thought that probably, I mean, even though like he is not having any evidence of syphilis into the peripheral blood, we thought that could it be tabes dorsalis, because I mean this pain is not typical of tabes. Could it be post-herpetic neuralgia, even though like it is encircling and there is no history of herpes zoster, or he is a psychological patient, like I mean, because I mean he's get depressed, or could it be because of HIV infection? So we did examine CSF. The protein was 51 milligram per deciliter, sugar was 53, Pandey's positive, total cell 35, predominant lymphocytic, CSF VDRL, Craig, India, varicella zoster IgG negative. Syphilis ELISA performed into the CSF was negative. We don't have access to the FT-ABS, so we performed ELISA, which was negative. CSF viral load was 33,560 copies. Plasma viral load was undetectable. CD4 was 356. So he put a provisional diagnosis of HIV myelitis, and ART was changed to indinavir ritonavir to these patients. And after 1 month of follow-up, within a 4 weeks time, there is no complaint. And he is still on indinavir ritonavir based therapy without symptoms. So I just look at the literature. Why? I mean, I get this paresthesias in HIV with CSF viral escape without any central nervous system disease. So this is the first case in my practice where the CSF escape with the spine involvement without CNS symptoms. So I looked at the published literature, and I could see a very good paper from Chemistry in Clinical Infectious Disease 2010, where they described 11 patients with CSF viral escape with fully suppressed the virus into the peripheral blood, and patients are having neurological symptoms. Out of this 11, the 3 patients had a spinal cord involvement. The first patient in this, the published literature was on the fosemprenavir plus tenofovir emtricitabine, and this patient has tactile allodynia, exactly similar to our patients. CD4 count was 432. The CSF viral load for this patient was 870, but this patient has detectable plasma viral load, but it is more than 1 log in the CSF, so probably this patient is also in the failure. The second patient in this literature has lower limb dysesthesia and hypoesthesia, again with good CD4 count and CSF viral escape. And the third patient has both the higher functions as well as the patient is having the lower limb dysesthesia, and where the CD4 count was 147 and CSF viral load was 586 with undetectable viral load into the peripheral blood. That means that while we are concentrating on the central nervous system disease, these patients can have the spinal cord symptoms and the paresthesias. And in this study, what they described that CSF cellularity and biochemical abnormalities were found in all but 1 patient. So out of these 11 patients, the 10 patients has CSF presence of CSF lymphocytes plus biochemical abnormalities. The proteins elevated, median was 0.85 milligram per deciliter in the range of 0.45 to 3.64. The pleocytosis was observed in 8 out of 11 patients with the medians, the white blood count were 31 with the range of 6 to 270 cells. All CSF samples were negative for bacteria, fungi and other viruses. The all patient had MRI abnormalities consist of T2 weighted sequence showing white matter hyperintensities which suggestive of HIV encephalitis in 9 patients and myelitis in 2 patients. Now in this study they also discuss about the response to the change in treatment. What they described that all the patient improved clinically within 4 weeks after making appropriate change. The comatose patient was extubated 2 days later. The patient's neurological functions improved, but the cerebellar syndromes continue to be manifest. So most of these patients, once you make a change in the anti-HIV medications, you expect a quite rapid response within a 4 weeks time. A median of 6 weeks, that is 2 to 16 weeks after treatment modification, the CSF samples were monitored, and 9 out of 11 patients showed a normalization in the cellularity as well as the protein level, and the viral load becomes less than 200 in all patients. Now coming to a case 2. Now any question?
Well, it's a fantastic case. What I find strange is the fact that there was absolutely nothing on the MR scan of his
Yes.
I don't know where Ashish is. I mean, not because I was expecting a little area of, I don't know, transverse myelitis or,
exactly.
or change of something, but there was nothing.
He has more of radicular symptoms, I imagine, rather than cord symptoms. So I don't know whether we'll see anything in the cord, because if you were to have any signal abnormality, you would have long tract signs for sure, which don't seem to be the feature.
Yes.
And also, I mean, with him, there was logic behind it. Going back to that lovely word I've used, he was on azathionine, ritonavir, and
Plus,
Truvada.
yes.
Low CPE score. You switch him to a high one, he gets better. Looking at some of the cases you described, the first of them, and they made the point of the series that they all sort of got better. The first one had a very high CPE score already, and the only way you could actually improve it would be to add another drug. And so I can't remember who was asking, but you know, whether there is a cut-off where you say CPE score above 8's okay, below 8's not okay. I don't think you can do, because if you look at the second one,
Yes.
you know, azathionine, 3TC, efavirenz. Well, that's
excellent.
Fantastic. I mean, you know,
Yes.
it's difficult to improve. It's already 4 drugs. So how you'd improve that, I don't know. So it's difficult. Maybe, you know, we go on these CPE scores, but in fact, for the individual patient, drugs don't penetrate quite so well in one individual, and another set of drugs would penetrate better. I don't know. Fascinating case, though. Really.
Now coming to a case 2. This gentleman is 46 years male. He is diagnosed in 1997 and he has received antiretroviral therapy, and he has a controlled disease, and the last regimen of this patient was Truvada plus lopinavir ritonavir. and he stopped treatment for 4 years and attended our clinic in March 2012. Before he came back to our clinic, like he has restarted his previous ART since last 2 weeks by his own. And when he came to our clinic, the CD4 count was 78, the viral load was 1,871 copies. So I just continued the same ART and asked him to have a very close monitoring and just to look at, reassess the efficacy of the same old regimen that he has stopped before 4 years. He has a good virological response. I will show you the table of CD4 as well as the viral load response to this guy in next slide. So in June 2013, he came with the weakness following a fall in the bathroom and with transient altered sensorium. So he was referred to a neurophysician. So he thought of some TIA because he has a fall, he has some transient loss of consciousness, and MR-angio was done. It was not showing any abnormality, and he was prescribed aspirin by a neurologist. But he has a progressive neurocognitive deterioration after these episodes with memory loss, inability to perform a routine work, which progresses to complete muteness. He has a bladder incontinence, and he was brought to a hospital with altered sensorium. So he was admitted in July 2013. And this is the CD4 and the virologic response. Look at this. Like after restarting, the CD4 count was 78. It has increased to the 273. This is a baseline viral load. And in November 2012, the viral load is 160, but still detectable into the peripheral blood. The CD4 count remains static. It is 233. In Feb 2013, it is 273. In May 2013, his CD4 count was 399, and viral load is still detectable, 633. So this was in July 2013, where he has significant neurocognitive decline. The CSF examination was done in hospital, showing the protein was 69, sugar was 45, with the RBS was 96. Total cells were 90 with 90% lymphocyte. The CD4 that we did from the CSF showing 64% CD8 and 23% CD4. The CSF viral load is 4,422 with the plasma viral was 633. So definitely it is less than 1 log than the peripheral blood, and the CSF was negative for other infections. So his antiretroviral were changed to raltegravir, darunavir, ritonavir plus AZT and 3TC. Dexona was given on day 1, followed by injection Solumetol 500 mg daily for 3 days, followed by prednisolone for 2 weeks. The clinical improvement was noted after 1 week, and he was discharged. So now he has started speaking something. He was trying to follow the verbal command, so we discharged him because he was otherwise stable. And the first follow-up that we had after 2 weeks of discharge from the hospital, there is a remarkable improvement in the neurocognitive functions. He has attained a bladder control, and he is now talking sense, and the higher functions has improved remarkably. So probably what we think that probably we are dealing with CD8 encephalitis in this guy, and this is a very good paper published in this year's CID. CD8 encephalitis in HIV-infected patients receiving combination anti-HIV medications, treatable entity. So what do you think, Wilkins? Like, could it be a CD8 encephalitis? Because we gave him a good amount of steroids.
Well, yeah. Yes, it could be. There's no... the CSF, did it go off for cytology? Did I miss that?
Yeah.
You got CD8, but did they see any abnormal cytology, cytological cells? Nothing at all.
Nothing. No. They have not mentioned.
I mean, the only case I've seen was diagnosed on biopsy, so I mean, it's very rare. I mean, it's been increasingly recognised over the last 2 or 3 years, and the steroids, of course, they muddied the water slightly because you've changed the HIV treatment, you've given them a much higher CPE score, and you've given them steroids. And the most important thing is the patient's got better, but you're not quite certain quite what's made the patient better. So I don't know. I think it's a good diagnosis to make, but I'm not certain. Were you certain?
No, we were not sure, like, even though like we treated him like a CD8 encephalitis. But let me discuss what is CD8 encephalitis. The key features of CD8 encephalitis is acute to subacute neurological symptoms that my patient was having. The prolonged duration of HIV, more than 10 years, that my patient was diagnosed in 1997. The CSF lymphocytic pleocytosis with predominant CD8 cell, and it should be more than 65% into the CSF. The CSF viral escape with virologic failure, like my patient was having the detectable into the peripheral blood, and there is a definite CSF viral escape. And the minor infections that triggers CD8 encephalitis. Generally, if we perform a brain biopsy, which can show astrocytic and the microglial activations, and if you do a immunohistochemistry for CD8, and you will find perivascular infiltrations by polyclonal CD8 lymphocytes, like in this picture. You can see there is a massive perivascular CD8 infiltrates, and the MRI is probably very crucial and key to diagnostic of this perivascular enhancement. And now I have questions to Ashish, because what they describe that if you are doing a MRI sequences with magnetization transfer after post-gadolinium, so after contrast, probably what you can see here, if you can concentrate here, what that characteristically describes is linear enhancement like this. Here you can see there is a linear periventricular enhancement with some nodular enhancement into the brain parenchyma. Patient has other evidence of HIV encephalitis, and in diffusion weightage image you will see the same area will show area of vasculitis. So can we get the magnetization transfer and the gadolinium enhanced image, and can we look at the CD8 encephalitis when patient is having appropriate clinical plus CSF examinations? Because what author recommends that this is a new complications of HIV infection which responds to the methylprednisolone, and the clinical CSF and the radiological features may suffice for the diagnosis of CD8 encephalitis in HIV infected patients.
Actually, I was going to discuss these entities in the last part of my talk. That was their technical considerations. One of them is magnetization transfer suppression. What it does is it enhances the contrast to noise ratio in the image. It is easily available and doable almost on all new generation MR scans. So on 3 Tesla it is definitely possible, but even on 1.5 Tesla it is generally possible. There is a little bit of time penalty that you pay for doing this sequence. It brings out the enhancing lesions. It makes enhancing lesions more apparent than what they would be on a non-magnetization transfer suppression scan. So we routinely use it nowadays, at least one sequence post-contrast with MTS. That has become a routine now.
So can we pick up such?
About the diagnosis, I would say these images, they just indicate there is perivascular infiltration or enhancement. This is extending along the penetrating blood vessels. This can be seen in any form of angiitis, basically because it is inflammation of vessels. Second thing is it can be seen in angiocentric neoplasms like angiocentric lymphoma, which also may respond to steroids, and lymphomatide granulomatosis, which comes in the same spectrum. So this is a non-specific finding as far as imaging goes. It can be seen in number of conditions.
So any comments on the diagnosis of CD8 lymphoma?
I think you've gone through it very carefully. I've only seen one case. I don't know how many cases you've seen. It does seem to fit the criteria. This man, he's got a lot better, the most important thing. And the trouble with steroids is they make so many things better. That's a good thing, really. So I can't comment. I mean, it does look like he's got features that are consistent with it. But his neuroradiology, I mean, the cases you would show the four together, those are the cases from the paper, aren't they, that show the classic features. And he didn't show the classic features on his, no.
So this was my last case. So thank you very much for the listening. And now I invite Dr. Nalin.
Thank Abbott, and being a part of HIV, I think, in fact, I would request all of you to join us, formally also, as we are here informally, because it's a absolute academic group, and we all get a chance to participate and act. So, I mean, just carrying forward Ashish's the opener batsman. Maybe I'm one of the tail handlers. Let's see how I handle it. So, going into a little more details of PML, we have had a very, very, very good exposure, regarding the neuroimaging. So I won't go into all those details. And this patient was a 57 years old male, and he was hospitalized with complaints of vertigo, and he came with a GI bleed in June this year. Initially, he was diagnosed as probably CVA with multiple cerebral infarcts, on a casual examination. He had history of old pulmonary tuberculosis and COPD. On examination, he was conscious, obeying only non-verbal commands. He was aphasic. He had bilateral case-evoked horizontal and rotational nystagmus, left 7th and bilateral 9th and 10th cranial nerve palsy, right hemiparesis, power was 3/5, and right plantar was extensor, left was flexor, no meningeal signs. His vital was stable. He was a little pale, and other systemic examination was normal. I'm sorry with the quality of this picture, I couldn't get the whole, but this showed some lesions in the parietal area and in the cerebellum. So the initial thought was that could it be infarct or could it be something else, but then we took some opinions, and our radiologist obliged us, and he said that this could be something like a PML. So then after stabilizing the patient, we did all the tests. We found that he was HIV positive. CD4 was 189. Viral load was modest, 76,000 odd. And we did a PCR for JC virus, which came positive. The report came almost 3 weeks later. Quantification was not done. It proved to be very expensive. All other investigations, CMV, crack, TB, toxo, etc., they were ruled out because of lack of evidence. So he was started on ARRI in July, which he tolerated well, thank God. I mean, I was suspecting that he might get some CNS symptoms with effervescence. And he showed some signs of improvement in response to commands and cognitive functions. Because initially he was totally unresponsive. He started becoming responsive. He started improving, and over 3 weeks' time he showed good improvement, and we thought that probably we have won the battle. But then again, he had another bout of hematemesis, not a very big hematemesis, it was a mild hematemesis. Probably he aspirated, desaturated, he had to be intubated and ventilated again. X-ray chest showed right-left zone haze. He was started on high-grade antibiotics. He had to put on ionotropes. Tracheostomy was done. He had a lot of secretions. Bowel was sent for culture but was non-contributory. And his right hemiparesis become worse. Contrast enhanced MRI showed white matter lesions as before with increased enhancement. So then we thought that, apart from this probably some sort of hypoxic injury to the brain, we thought maybe it could be an iris, and we started him on a high dose of steroids, and he started improving again. And neurologically he was much better. He was extubated. He was shifted out of the ICU. Then dexamethasone was given for almost 4 weeks, and then we started tapering it off. His X-ray chest cleared. Antibiotics were stopped. Patient stabilized, but when we reduced steroids, we couldn't give steroids, forever. He again started he started deteriorating again, and very, 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 very rapidly he went into coma. He had to be reintubated, but then he developed vasomotor collapse, and then he got cardiorespiratory arrest. And almost 3 months of hospital stay, with 2 or 3 ICUs in and outs, and steroids and all this. Ultimately, we lost the battle. So, actually, after 3 months at Apollo Hospital, he must have spent a couple of lakhs or maybe more, and ultimately we, landed with a sad outcome. So this was the first. We see a lesion, white matter lesion. This was the second MRI. enhancement is much more. This was the third one. So this was it. So then, where we went wrong, what we could have done better. This guy had all the features of PML. Could it be something else also? So I think this has already been tackled. CD4 count more than 500, aseptic meningitis, meningoencephalitis, Bell's palsy, Guillain-Barré syndrome, brachial neuritis, transverse myelitis. Of course, CVA can happen at any time. CD4 count between 200 to less than 500, TB meningitis, Guillain-Barré syndrome, DSPN, distal symmetric polyneuropathy, polymyositis, motor neuron disease. Then CD4 count less than 200, HIV-associated dementia, TB meningitis, cryptococcal toxoplasmosis, PML, primary CNS lymphoma, nocardia, brain abscess, DSPN again, vacuolar myelopathy, CMV encephalitis. Of course, ischemic CVA can happen anywhere. Herpes encephalitis, CMV radical. So these are the usual diseases one would consider in patients who present like this clinically. Would you like to make any comments before I proceed further?
Hello. So that's on that. Right. Well, I don't think in HIV, I don't think I've ever seen PML with CD4 count in the 170s, whatever it was. So I'd be suspicious, and I know you had a qualitative test and it wasn't quantitative, and you wonder whether it was right on the borderline between negative and positive, and I wondered if you repeated it when the patient went to his ICU on, I don't know, the first or second occasion. Did you repeat?
No, we didn't repeat.
So, and I don't know, I'll wait until I get Ashish's opinion on the scans, but I would not have immediately said that was PML. And I would have wondered if I could persuade a surgeon, and if the patient was fit, it doesn't sound like he was fit, about possibly getting a biopsy of that, because the improvement on steroids is the strange thing, and the dependency on steroids, which makes you wonder whether in fact there is a more sort of steroid responsive condition that is causing this problem, and that there is an element of vasculitis of some kind.
Probably that's what I wanted to bring out, that probably we went wrong somewhere in pinpointing the diagnosis. We really couldn't do we involved a neurosurgeon, but he couldn't be taken to the OT and he didn't really prefer to do any brain biopsy.
I think the imaging didn't look typical of PML at all. I thought it was sort of defying all the criteria that we would use to call it PML. In the sense, it was not supportive. It was involved in corpus callosum predominantly. It was involved in left frontal periventricular white matter, and it was diffusion restricted. So unless it is PML iris, we generally do not see diffusion restriction. And there were too few supratentorial lesion to explain his clinical condition. So I would think that there was something dissociated between what.
So what other differential diagnosis would you put in this patient?
Actually, all the images that you showed at least appeared to me were only flare images. I would look at contrast enhanced MR at least one go to check that there is nothing enhancing, because if there is something enhancing, then I am not thinking of PML straight up. So I thought we can go back. I thought I saw all the images which were flare, and none of them were contrast enhanced.
Yeah, they are all flare images. But our contrast enhanced actually didn't really pick up much. I didn't include all that, because that would have been a big one.
Because this could fit into vasculitis, or it could.
We thought of vasculitis, yeah.
Lymphoma is another bet. You really have to do a spectroscopy.
No, that was all negative. This was just to compare. We have done all that. That was all negative.
So you say the EBV on the CSF was negative?
Yeah.
Did you?
You did EBV as well. We did herpes, we did EBV, we did toxo, we did all. Everything was done. So, we really didn't quantify. Had we quantified, that would have really, made the difference. But that's why, especially mentioned that we couldn't quantify. So maybe there was something amiss here.
if you look at pathogens and you look at how typically it should be, really the only CNS pathogen at that sort of level of CD4 count that would give you some vasculitic component would be TB. And I don't know whether that could have been tuberculosis sort of underlying it all, or whether again it didn't seem to change very much. I mean, did it get bigger?
No, it didn't change much.
I don't know if you've got any comments about the mass lesion, whether you can say anything about it.
I think that the distribution and the appearance of new lesions is what appears from the three images that we are seeing. I think such rapid change, vasculitis is something which is high on the cards, is what I would think. Whether it is primary or not, I don't know, but it is vasculitis of some sort. Again, it is affecting areas which are watershed, penetrating vessel affection. So I would go for that. And then there was diffusion restriction also at the margin of one of these lesions. So all in all, I think vasculitis would have been a better bet.
Anyway, we discussed this. Vasculitis was one of the main differential diagnoses, but then ultimately our radiologist, they said that no, well, it looks more like a PML. And of course, the CD4 count was not very low. That was one thing which was not very much fitting into it, because, of course, I mean, we have seen some earlier patients with CD4 count more than 200 also, very, very typical PML, and they have done well with heart. They have improved without any without any other intervention. So whether
the only ones I've ever seen with CD4 counts like that have had a very low CD4 percentage. Or they've been on heart and suddenly it's gone up from 38 to 200, and then they've developed their PML and presented.
Or of unmasking. Yeah, unmasking. No, we have seen some PMLs earlier, but this was something which was really, I mean, I was not very sure. We thought it's PML, and then probably that's why I brought this, because this is food for thought for all of us. That maybe just one. If you don't see anything else and you find, JC virus positive, whether it is a good enough reason to pinpoint the diagnosis, or should we go further and maybe do a brain biopsy and then prove the diagnosis?
Well, I mean, the sensitivity of the PCR.
It's about 70.
Presumably, it's like.
There's about 70% odd.
That's more than that. Specificity and sensitivity are very good. So, if this was a commercial kit that was used and not an in-house, then you would expect this to be highly likely positive. But then again, it's the question of the cutoff, being just positive. So I think it's like all these cases, it's incredibly difficult.
So do you think a quantification should be done in all patients? Because
yeah, I think it should be done in all patients. Where you can get it done, I think it should be done. And of course, it goes down very rapidly with heart. Which makes it even more difficult when they present at 6 weeks having an ARIS type PML, because their JC and their CSF has come down quite a bit already.
Okay, so I'll just run through. I can see Atul pointing at the watch.
Because we have one more presentation.
Okay, well, I'll just quickly go through PML, and it's a demyelinating disease of CNS characterized by widespread lesions due to infection of oligodendrocytes by a human papovirus. The virus was identified as the etiological agent in 1967. It's called JC virus, named after John Cunningham, from whom it was first isolated. And virus has worldwide distribution. Approximately 85% of adults are seropositive for JCV. So it's a virus which is like CMV, One gets infected in the childhood, and when the immunity goes low, then it can cause a, pathogenic lesion. So virus enters via respiratory route. Primary infection occurs during childhood, remains latent with mild respiratory illness, and during primary infection becomes latent in the kidneys, lymphoreticular tissues, brain. In the setting of an immune suppression, there is reactivation causing viral replication and dissemination. It occurs in individuals having AIDS, hematological and lymphoreticular malignancies, autoimmune rheumatological diseases, organ transplantation. It manifests as a focal neurological deficit, usually with incidence onset and steady progression. It occurs in any region of CNS, especially in the occipital lobes, frontal parietal lobes, and cerebral peduncles. In fact, if it is occurring in cerebral peduncles, it has a poorer prognosis. Individual lesions expand into the white matter, causing initial symptoms like partial deficits, weakness of one leg that worsen to involve a larger territory, And seizures can develop in 20% of patients. It can be with both HIV1, HIV2. It's currently one of the AIDS-defining illnesses in HIV-infected patients. PML occurs in HIV-infected patients with a poor immunological status expressed by a low CD4 count. In fact, usually the CD4 count is below 100. The incidence of PML has decreased less dramatically in the HART era, and PML and HIV/AIDS reign in India. So this is a paper which was published, study done in AIIMS, and they conducted the study over a period of 5 years. And they found that the aim was to understand the frequency of PML in India, clinical features, survival, and they found that 1.2% of patients had PML amongst all the patients attending the clinic. 89% were having a CD4 count of less than 200. 56% PML was the first presentation of AIDS in these patients, and the median survival was about 7.6 months. And they concluded that more than half of the patients' PML was the first presentation. Advanced immunosuppression was common at diagnosis, and HIV-associated PML is rare in India, will likely to become rare in the future if efforts are directed at early initiation of HART as recommended by WHO. Now, there's no specific treatment. The main approach is to reverse immunosuppression. Approximately half of the patient PML in the setting of HIV experience a remission after initiating HART. And data on those drugs like mefloquine, cidofovir, etc. is inconclusive, not recommended. So only HART is recommended. Now, as far as IRIS is concerned, which we thought probably happened, treatment of PML involves reversal of immunosuppression leading to an increase in CD4 cells. This immune reconstitution may trigger an inflammatory reaction in some people receiving ART, and it is known as IRIS. Although it's benign, but it can sometimes be severe, and it can be mistaken for true disease progression. Sorry. So it is one of the, PML is one of the most frequent OIs as well as IRIS. In the HART era, between 10 to 20% of the PML patients develop inflammatory manifestations, and most often PML IRIS starts between 3 to 6 weeks. But it has been described between 1 and 104 weeks. I think Atul was concerned about. It's mediated by JC virus specific CD4 lymphos. Histologically, diffuse mononuclear perivascular inflammation infiltrated in cerebral cortex with positive JC virus in situ hybridization, associated with contrast enhancement and MRI. And it may be associated with clinical improvement or severe PML disease and death. Now, clinical presentation could be transient worsening or development of new neurological symptoms, paradoxical vis-a-vis unmasking. In severe cases, signs and symptoms of intracranial hypertension is observed. Contrast enhancement and edema denoting blood-brain barrier disruption secondary to inflammatory process observed on MRI. Brain biopsy usually shows CD8 T lymphocyte infiltrates in the areas of demyelination, which is different from classical PML, where inflammatory infiltrates are mild or absent. What is the management? We give hydrosteroids or discontinue ART, but discontinuing ART is likely to be counterproductive. So corticosteroids has been used to control the local inflammatory reaction, reduce the associated cerebral edema. Steroid treatment should be as short as possible and not overused. So in this case, probably, we used it for a longer time, and the moment we stopped it, the patient collapsed. So I think probably there was something else associated with it. Mild swelling, edema, or contrast enhancement might be noted in some patients who respond favorably to ART, but most often these complications require no additional treatment if the patient is clinically stable and has no sign of impending brain herniation. In those with progressing clinical deficits and neuroimaging features suggesting inflammatory disease, corticosteroid treatment is justified. Stopping ART in the face of PML IRIS is still not recommended by anybody, although some people have done it, but it's not still recommended. Thank you.
So I'll be presenting two case vignettes with the same diagnosis. So first case was a 47-year-old farmer who was HIV positive, was diagnosed HIV positive on April 2013. He presented to us on 29th of April with high-grade fever since 1 month, cough, poor appetite, weight loss, change in voice, and drooping of the left eyelid since 2 weeks. He had no history of altered sensorium, seizures, headache, no cognitive issues. The bowel bladder was absolutely normal. There were no motor or sensory symptoms, and there were no visual or auditory symptoms. There was no significant past medical history. He was a tobacco chewer. On examination, he was febrile. He had oral candidiasis. on central nervous system examination, he was dysarthric. He had a left eye ptosis. The other cranial nerves, fundus, absolutely were normal. Reflexes were 2+, plantars were flexors, and there were no sensory or meningeal signs. He had a normocytic normochromic anemia with neutrophilia. Urine showed 1+ proteinuria. His LFTs were normal. He was detected diabetes for the first time. His HbA1c was 9.2. He had a CD4 which was done outside, was 21. His USG abdomen showed hepatomegaly with multiple foci of calcifications, and his USG neck showed bilateral necrotic nodes. Because he had ptosis, we did an MRI brain which showed small gliotic areas in the right middle and inferior temporal gyri. Rest was normal. There was no explanation for his ptosis. We did a CSF. The CSF showed raised proteins. His sugar was normal, and it was acellular. His CSF crag was negative. So we went ahead and did the neck biopsy, which was AFB positive. We ran a Hein on it, and it was confirmed to be MDR-TB, which was HR sensitive. We also thought that the ptosis could be because of ocular myasthenia, and that is why we did an ICE test. An ICE test is just you apply ice on the eyelid. The principle behind it is that low temperatures, the neuromuscular transmission increases, and the ptosis should improve. But that was negative. And we started him on HRZE, PCP prophylaxis, and then also treated his diabetes. He took discharge on request on 5th of, he was admitted on 29th. After 1 week, he took discharge to be readmitted on 14th with nausea, vomiting, anorexia. The ptosis was persistent. He had increase in the speech difficulty. There was increased speech difficulty. There was dyspnea at rest since 3 days, and there was vague chest pain. On examination, he had tachycardia. There were bilateral V's, and the CSF examination, as compared to the previous, had facial asymmetry. The left ptosis was persistent. His lab again showed a normocytic normochromic anemia with PML leukocytosis. He had hyponatremia, which we thought was hypovolemic. His LFTs were deranged. AST was more than ALT. Because of AKT hepatitis. Because he was very tachypneic and his ABG showed hypoxia and respiratory alkalosis, we did a D-dimer to rule out embolism. Because the D-dimer was high, we did a CT pulmonary angio, which again was normal. His echo was normal. So we started him on supportive treatment for AKT hepatitis. We added levofloxacin, continued mycobutol, and later on added rifampicin. We also wrote a neurological opinion for his left facial weakness and ptosis, but the neurologist again suggested it could be an ocular myasthenia and suggested pyridoxine stigmin test, which came out to be negative. Review with the neurologist said it could be a mitochondrial ocular myopathy, but he had no external ophthalmoplegia, no external ocular ophthalmoplegia, just ptosis. So mitochondrial ocular myopathy was very low on cards. After 3 days, the patient had proximal muscle weakness, both in the upper limbs as well as the lower limbs. The weakness was more in the lower limbs. He had severe muscle tenderness. We did a CPK, which was very high, and inflammatory markers HSCRP and ESR was also high. To rule out vitamin D deficiency, he was vitamin D insufficient, and we also did a EMG NCV because it was an acute onset tender myopathy. The EMG NCV showed severe myopathic pattern with underlying sensory neuropathy. So later we decided to do a muscle biopsy. We thought of inflammatory myopathy, acute inflammatory myopathies like polymyositis, or infectious like toxoplasma or trichinosis, or metabolic we had already ruled out. And so we started empirically steroids till we got the muscle biopsy report. In the meanwhile, the patient worsened and he took a discharge against medical advice. I'll discuss the diagnosis later. This is the second patient, who is a 45-year-old male who is also a farmer by occupation, who presented to us on 22nd of June with high-grade fever since 2 weeks, pain in the lower limbs, and there was weakness. There was proximal weakness in the lower limbs. He was unable to sit up from the squatting position. He had poor appetite, significant weight loss, There were some ulcers in the lower back. The bowel and bladder were absolutely normal. His past history, he was diagnosed HIV in October 2007 during his routine pre-op evaluation for hemorrhoids surgery. His CD4 at that time was 17. His viral markers and serum crag were negative. He was initiated on D40 3-decynevirapine. In March 2008, his CD4 had increased. His viral load was less than 400, but later on he did not adhere with the drugs. In March 2000, because of poor adherence in 2010, his CD4 had dropped, his viral load had increased, and he was switched to TDF, FTC, and atazanavir ritonavir. On follow-up, CD4 and viral load, where CD4 had increased, viral load was undetectable. When he presented to us, again, because he had discontinued his ART again, his CD4 was 5, CD4% was 12, and his viral load was more than 30,000 copies. He had history of 2 episodes of herpes zoster and a history of tuberculosis 7 years ago, for which he had taken DOTS for 6 months. On examination, he was febrile, he had tachycardia. There were some erosions on the back which were healed herpes zoster with a few furuncles on his legs. His cranial examination, again there was a right-sided ptosis with conjunctivitis. There was proximal muscle weakness, more in the lower limbs. He had significant muscle tenderness. His reflexes were depressed, just 1+. His plantars were flexor. His sensory examination was normal. There was no back tenderness to suggest any spine involvement, and his fundus was normal. Other system examination were unremarkable. On examination, he had a normocytic normochromic anemia with a PML leukocytosis. This PML leukocytosis kept on worsening. His sodium, again, he had hyponatremia, which may be because of hypovolemia. His serum crag VDRL was negative. His CPK was not very high. He was vitamin D insufficient. His thyroid functions were normal. His inflammatory markers such as HSCRP and ESR were raised. Workup for anti-nuclear antibody was negative. His serum procal was normal. His blood cultures were sterile, and radio imaging was normal. His EMG NCV showed mild sensory neuropathy in both lower limbs, and his MRI brain, because of ptosis, which was done because of ptosis, was again normal. So we started him on supportive treatment, awaiting supportive treatment. We replaced vitamin D, started him on ceftriaxone because of fever and DVT prophylaxis, but his weakness progressively worsened. He had severe myalgia and was bedridden. Fever continued, and that is why, as a workup for fever, we did a PET scan, a FDG PET scan, which showed increased uptake in muscles, especially in the deltoid and the right quadriceps. And that is from where we did a muscle biopsy. Again, we initiated this patient on prednisolone, awaiting the biopsy report, thinking it was an inflammatory polymyositis. And the muscle biopsy report came as toxoplasma myopathy. So we initiated anti-toxoplasma treatment, but the weakness worsened over the next 2 days. The patient had a sudden cardiac arrest and we could not revive him. So after both these patients, we decided to send the muscle biopsy to NIMHANS Bangalore, and from there we got a report by Dr. Yasha, and which was also confirmed at the CDC Atlanta. The report of the first patient was the muscle architecture was preserved. There were cystic structures which were spores within the myofibers. Because the IHC for toxoantigen, which was reported as positive in our hospital, was confirmed twice, which was negative. Because the report was, the impression was microsporidial myositis. Because microsporidia closely resembles fungi, it also took some fungal stains like the pus. And this was the report of the second patient, which also suggested it was microsporidiasis. The speciation could not be done, so they said it was either Plethystrophora or Trachyplestrophora species. To confirm for speciation, to confirm species of microsporidia, which requires transmission electron microscopy, is underway at NIMHANS, and DNA sequencing at CDC Atlanta has been planned. So these are the microsporidia. This is the histological pictures. The pink. These are the pink. This is the trichome stain, and this pink, which you can see infiltrating the muscle fibers, are the microsporidia. This is the fluorescent staining, which showed infiltration by microsporidia. So microsporidiasis is a protozoal disorder. Around more than 1,000 species are known, over 150 genera. Around 10 species are known to cause human disease. It is either zoonotic or waterborne, enters the body either by ingestion or inhalation. In immunocompetent patients, it is asymptomatic and a self-limiting disorder. In immunocompromised, it causes disseminated disease. It can involve the GI tract, causing diarrhea, wasting syndrome, encephalitis. It can cause conjunctivitis, keratitis. It can cause sinusitis. It can cause myositis, even nephritis, and in some cases, even myocarditis and endocarditis. So, in the GI tract, it causes chronic diarrhea, weight loss, bloating. It is a non-inflammatory diarrhea. It generally involves a small diarrhea causing non-inflammatory diarrhea, secretory diarrhea. It can also invade the biliary tracts, causing sclerosing cholangitis and cholecystitis. The diagnosis is by stool examination and either by trichome stain or fluorescent stain like chromatrope or calcofluor. The diagnosis, if you cannot get the stool, the diagnosis is through either biliary aspirate or jejunal biopsies. If urine, it also causes nephritis, and if urine is positive for microsporidial spores, it indicates there's a disseminated disease, especially by encephalocytosome species. The definitive diagnosis, confirmed diagnosis and speciation is by transmission electron microscopy and PCR assays. It also involves the muscles. The three species which involve the muscles are plestophora, trachyplestophora, and anacalia. It causes severe myalgia, progressive muscle weakness, can be associated with ocular myopathy, as in our both cases. Sometimes also involves the myocardium and also causes endocarditis sometimes. The treatment is hard. There's antiprotozoal drugs like fumagillin can be tried. Species like enterocytosune responds to fumagillin, and species like encephalocytosune responds to albendazole. Albendazole is to be given for 400 mg BD for 4 weeks until the immune restoration. So the summary for this is microsporidial disease is an important diagnostic differential diagnosis in advanced HIV disease with a severe diarrhea and wasting, or with myopathy with and without ocular involvement, and muscle biopsy should be pursued for definitive diagnosis. Thank you.
I've certainly seen, obviously, in the eye. I've also seen it unexpected sites like in the lung. When you think somebody's got PCP, and they invariably have very low CD4 counts, and you are surprised by it. And it's incredibly difficult to treat. We use nitazoxanide. We used to use paramomycin for BioNuC. The others are all pretty easy to treat, but that one in particular is very difficult to treat. And of course, get the CD4 count up. Get the CD4 count up, and things start to get better. But great cases. I mean, really great cases.
Yeah, so far total 17 cases has been reported for microsporidial myositis. We have submitted 5 cases to Journal of Infectious Diseases awaiting a response, and these are 2 more cases, right? And the treatment is terribly difficult. And the first 2 patients of our series, they also died, and we tried the same thing, like we initiated them on prednisolone. And the second case was diagnosed to have candida myositis, and later on it turned out to be a microsporidial myositis. So with the third case onwards, like we were very vigilant, because now we know that this is a life-threatening conditions. And in published literature, like all the patients were diagnosed post-mortem. None of the patients were diagnosed ante-mortem, that they are having microsporidial myositis. So from third case onwards, what we did, because we do not have an access to speciate them, whether which species they belongs to. So we give them a cocktail therapy of sulfadiazine, pyrimethamine, betazoxanide, and albendazole, and fluconazole. So we give them 5 drugs to take care of all 4. Now there are 4 species which can produce myositis. So we give them cocktail of antifungals, anti-helminthics and everything, because now these microsporidia are classified into fungi rather than parasites. And all last three patients, they survived, and they are doing great on anti-HIV medications. In the third patient, we stopped this combination therapy after 7 to 8 months' time. And second patient, he has responded nicely and put on anti-HIV medication, and he lost to follow-up. And the last patient, he has responded nicely. We have discontinued this therapy after 7 months, and he was on stable ART, but he has recurrence. Right? I don't know why he has
recurrence of microsporidia.
Myositis.
Okay.
With again rise in CPK and everything. But still he is surviving. So we have also lost 2 patients, 1 patient lost to follow-up. But this is a life-threatening condition, and it is very rare. So we need to have high index of suspicions to diagnose. So with this good cases, I thank you all. And now I will hand over the mic to
thank you, sir. On behalf of everyone here, I would like to thank the honorable speakers for their time and effort. And I'm sure everyone here has enjoyed the learnings today. I would now request Dr. Atul Patel to please present a memento to the speakers. To Dr. Ed Wilkins, please.
A picture of you.
yes.
Great. Well, thank you very much indeed. That's very kind of you.
Dr. Ashish Atre, please.
Yes, just come over here. Let me have one more photograph. This is a very good radiologist.
Thank you.
Dr. Nalin Nag, please.
Thank you.
And Dr. Wilkins, so can I please request you to present a memento to our chairperson for the day, Dr. Atul
I'm
Patel.
going to present one to you. Oh. No. Well, it's been a wonderful conference, and you've had some excellent speakers, apart from myself, and you've held it all together very well, and you're obviously a leader among men. So, congratulations. My honour. You're a big man, aren't you?
So, and I also can I please request you to please present a memento to Dr. Abhijit.
Sure.
You can collect it on behalf of. Thank you, Dr. Abhijit, for that presentation. Thank you, everyone, for joining the session, and please enjoy your lunch as well.